So I want to talk a little bit about 4 topics, and all of them, I think, present opportunities to talk about overlap between what PCORI is set up to do and aims to do and thinks it will do with its funding and what you do. Talk a little bit about the historical context into which PCORI was born, where patients were being put at the center of a number of things, and ultimately, through PCORI, at the center of research. Just a bit about how we are aiming to conduct patient-centered research, what our activities in that area so far. Talk a little bit about this thing called treatment heterogeneity and how that applies, I think, in public health settings just as every bit as much as those who put it into the legislation thought it would apply when you're trying to look at genetic markers and decide which drug to take. And then finally, talk a little bit about data and data infrastructure and PCORI, in particular our Board of Governors' thoughts on that. So this is from the Affordable Care Act, our purpose and you'll notice it's an extraordinarily broad purpose, to assist patients, clinicians, purchasers, and policymakers in making informed health decisions by advancing the quality and relevance of evidence concerning the manner in which diseases, disorders, and other conditions can be prevented, diagnosed, treated, monitored, managed, and after that's done, disseminate the research findings. And if you read a little further, you show that we need to change outcomes by 2017. So a tall order, and we do it by conducting comparative clinical effectiveness research. And that's, I think, the kind of the nub of what we can discuss tonight. Comparative clinical effectiveness research is quite attractive. It's an idea that caught my fancy, I think, when Sean Tunis wrote a paper in about 2002 or 2003 that we had talked a lot about as he was writing it. It is research that answers practical questions. It's questions of interest to patients and providers, and as the legislation says, also to policymakers, usually through head-to-head comparisons. So what shall I do? Which shall I do? It's conducted in typical patients or real-world patients and typical or real-world settings, not rarefied settings, not unusual patients. It is indeed effectiveness research. It considers a broader range of outcomes than most research bothers to do because it's trying to assist decision-making, and there you really need to know about the wide range of outcomes. So outcomes that are of interest to patients and to clinicians. It considers possible differences in treatment effectiveness in patient subgroups. What works for whom? And it goes without saying in some circles, but in others you need to say that it can be done with either randomized trials or observational studies. And we would say both are very important, they're complementary, and we anticipate funding both. And if you look at our funding to date, it's about 50% randomized trials and 50% observational studies. One thing we don't do is we don't do cost-effectiveness analyses or even cost comparison studies. We will fund studies. If you want to tell us about resource utilization, that's fine, but we don't want, in fact, we send back applications if they propose measuring total cost of health care and comparing them between 2 alternatives. That was fairly explicit in the legislation, more explicit if you talk about the people who wrote talk to the people who wrote the legislation. So they weren't crystal clear in the legislation, but they're crystal clear when you talk to them. And there's probably some very good reasons. I'm not going to go into this now. If it comes up in questions, I'll be glad to give you my spiel on it. But I think they made the right decision. I think there's plenty to do in measuring outcomes, clinical outcomes, outcomes that matter to patients. And by the way, the one cost that we reserve the right to study in any way we want is out-of-pocket cost to patients. So that is on the table. But this is wonderful research. And so the first little gesture I want to make vis-a-vis you, this crowd, is that this is just exciting research, period. Practical questions, real-world settings, multiple outcomes and looking for treatment differences, variations in treatments among subgroups. That's just cool stuff. And I would say, and I think you'll see, that we have applied this framework to a wide range of questions well beyond clinical choices, the narrowly defined clinical choices. And we'll get into that. Why is it important? Because in clinical practice, we practice within a remarkable amount of uncertainty. This is a recent summary of systematic reviews of 3,000 treatments that estimated, that concluded that for 50% of the common treatments done in clinical care, we do not have sufficient effectiveness information to know whether we're making the right choice. So just we practice with uncertainty. I had a good friend who fell and broke her shoulder in the garden just as spring was springing in Bethesda. She went to the orthopedist, and the orthopedist, right below the humerus, the orthopedist said, "You need a total shoulder replacement." And she couldn't believe it, but he said, I know that's drastic. I'm going to send you to, I'm going to recommend that you see another orthopedist for a second opinion. And here's the name of one if you'd like to see this one. So she went to the person that he recommended. That person said, "You should put your arm in a sling and wrap it tight to your chest for 6 weeks, and then then we'll start vigorous physical therapy." So 2 orthopedists that know each other, same fracture, 2 completely different recommendations. No evidence, clear evidence of which would be better. But that's, you magnify that across the wide range of conditions that people either try to make decisions for themselves or seek consultation. So where is this comparative effectiveness research in the continuum? Well, if you start on the left with basic science, where we're doing discovery of molecules, unraveling etiology and mechanisms of disease, and eventually you go through T1 translation and you're at clinical research, and you may do clinical epidemiology, you may do, but oftentimes you will do randomized trials for effectiveness, for efficacy and safety. Then we take it out into the real world in T2 research and T3 and T4 research, and we're looking at does it work in the real world, and then if so, how do we implement it? I would argue that PCORI comes here. PCORI is the last link in the chain, or at least the last one we've thought of to date. And it takes treatments that are in practice, and we believe that they have effectiveness, but for individual patients, we do not know which one's more effective. So I like to think of it as the very end. It is comparative, and it does look at outcomes, the outcomes that matter. And so that's PCORI. Again, one of the reasons, or not one of the reasons, but the fact that it lies out here explains why we feel that we can say, as we solicit applications, we want you to tell us why this piece of work will genuinely change practice. Because it is at the end of the line. It's this last decision, and if it's a genuine decision and if people are waiting for the answer, more often than not, it ought to change practice. So that's one of our actual requirements, is that you tell us in the applications why this is that particular study that's likely to change practice. End of the line research. So they didn't call us the Comparative Clinical Effectiveness Research Institute for reasons that you all know well. The death panels and rationing were just too much to countenance. So I think, and in fact, when I first got to DC from California, I went around and asked everybody I knew how PCORI got its name. And really, there is nobody that can tell you. All they can say is that it was very clear in the Senate that they did not want to call this the Comparative Effectiveness Research Institute. One senator was reputed to have said, "I don't care what you call it, you can call it Fred." And at some point, they grabbed the name Patient-Centered Outcomes Research Institute. And I think it had something to do with the fact that everything was becoming patient-centered about that time. So we had patient-centered care and shared decision-making. We had patient-centered medical homes coming onto the scene and showing that they could improve quality and actually reduce costs for complex, chronically ill patients, particularly if they linked in with community services. We had patients being involved in the planning of new services, for example, to improve safety or to improve access to care. We had patients even pulled into writing guidelines and defining appropriateness of care. We had nice examples of that. We had performance measurement that was beginning to pull patients in, not just to give them the responses to patient-reported measures generated by the quality improvers, but to tell the quality improvers what does it matter, what matters to us, what should you measure, what should the measures be. So, and of course it all goes back to its basis, I think, in community-based participatory research. So that is the kind of the grandmother discipline of all of this stuff, I think, at least of PCORI. I like to say PCORI, patient-centered outcomes research, is CBPR applied to clinical questions. But lest you think that healthcare thought up patient-centeredness, I know you don't think that healthcare caught up performance measurement or quality improvement or safety. I will tell you that I'm not quite sure how far back it goes, but customer centricity is huge. Ford Motor Company adopted a customer-centric approach in 2000. General Motors adopted a customer-centric approach in 2010. But General Motors, Ford said, we want to move from a supplier perspective to a customer perspective, from event transactions, that is sales, to the appreciation of the life cycle of the customer. We want to understand and respond to customer preferences and differences among segments of our customer population. We want to move away from off-the-shelf products and become more flexible and able to customize our services. That sounds a lot like healthcare is talking today. We want to treat customers as advisors in product development. So Ford Motor Company had it in 2000. They did not have it in 1900. Here's what Henry Ford said. If I'd asked my customers what they wanted, they'd have said a faster horse. So somewhere between 1900 and 2000, Ford Motor Company got the idea that including customers in the decision-making process, the product development, made a difference. So we also know that despite its name, PCORI was established in substantial part because of concern about national health expenditures. This recent paper suggests that after 2 or 3 years of modest growth, probably mostly because of the downturn in the economy, Medicare costs are going to begin rising in 2014 at a remarkable rate, Medicare and all federal costs, as coverage expands and economic growth accelerates. So we anticipate going back to about a 5.7% annual growth in healthcare costs. So a lot of concerns about rising healthcare costs continue. And this indeed was part of the reason that PCORI was formed, because it was believed that providing better evidence would, on average, modify costs and reduce costs as well as improve quality. So this is just some evidence that suggests that without doing cost effectiveness, without doing cost comparisons, supporting decision making, providing better evidence for decision making, providing the tools to support shared decision making, patient-centered decision making, may in fact lower costs. So a systematic review of 65 studies from the Cochrane collaboration found that that shared decision making led not only to increased knowledge of treatment choices and better expectations of benefits and risks, and improved alignment of the choices with patients, what patients reported as their values, greater participation in decision making, but also the lower use of several elective surgeries. Similarly, a study from Group Health in Seattle found 26 to 38% lower rates of elective knee and hip and knee replacement, 12 to 20% lower costs after a program in which orthopedists themselves participated in shared decision-making with patients. And a third study in retirees of 7 major employers on the East Coast found lower costs and rates of surgery for preference-sensitive conditions like back pain, angina, prostate cancer, and joint pain. So some evidence that as patients get better evidence and get involved in decisions, they are somewhat more conservative than the environment in which they're often cast, which is still a volume-driven environment. So some wisdom perhaps behind involving patients in care, even from the perspective of being worried about costs. And I say that, I mentioned this just to raise the notion that patient-centeredness and consumer or population centeredness, engagement of clients in all kinds of delivery activities is of great interest to PCORI. We're very interested in seeing that, particularly when it's done around a comparative study design. So I want to say a little bit more now about how we do research. Before we got started in July, or I arrived in July of 2011, and even before we hired more scientists, we set out to hire people that would do engagement. And to this day, we talk about the two intertwined pillars at PCORI being engagement and research. So we engage patients and other stakeholders, clinicians, policymakers, other stakeholders, in helping us identify topics to study. We've just named advisory panels, which will help us prioritize those topics. We engage them in reviewing the proposals, so our study sections have a total of 30% non-scientists, half patients, half other stakeholders. We require that they be involved on the research teams, both patients and other relevant stakeholders. And we do this in large part. In fact, I really enjoyed Jeff Levy's comments this afternoon in the session on the News from Washington, where he said, because this is a page from our book, get those end users involved as you're designing the study, as you're formulating the question, so that you know you have somebody waiting on the edge of their seat for the results, and they're the results these folks are looking for. It has to increase your chances of being able to disseminate and implement the findings. So get the professional organizations, get the patient advocacy groups involved from the beginning. And then we also involve these advisory panels and in other ways, reach out to stakeholders to help us evaluate our portfolio over time. This is, to many people, the most important slide in the deck. This just suggests the resources we'll have. In 2012, we had $150 million, and in 2013, approximately $300 million. From 2014 to 2019, approximately $500 million per year will flow into the PCORI Trust Fund. 20% of that goes to the Department of Health and Human Services, most of that to AHRQ. But the remainder is committed and spent by PCORI. And because we do have this lifespan that may end in 2019, will be reviewed in 2017. We will see, Congress will decide whether PCORI will live on. But to a substantial degree, we have to plan, number one, to have as many outcomes as possible by 2017, and number two, actually plan for the possibility that we may not be able to spend money past 2019. That means more spending, sort of front-loaded spending in 2013, 14, and 15. So that is a lot of resources, and I'm sure you're aware. So what are we going to spend the money on? One of our first major activities was the formulation of priorities. That's in the legislation. We've got to come up with national priorities and a research agenda. We formulated it. We put it out for public comment. We got a lot of public comment. We revised the priorities, and these are they. The first one is what you might think a comparative effectiveness research institute would study, the assessing prevention, diagnosis, and treatment options that patients face. We compare alternative options. We identify patient differences in response to therapy. We study patient preferences for various outcomes and build that into an ongoing portfolio of comparative studies that support decision-making at the individual patient and clinician level. But we also recognize that that would sit on the shelf, not be particularly effective, if we don't improve the healthcare delivery systems in which these decisions are being made. So we put a sizable chunk of our resources into improving healthcare systems. And I think this is, well, I'll hold that thought for a minute. But approaches such as, or questions such as, how do we improve systems to support patient self-management, to coordinate care for patients with complex and multiple chronic conditions, to improve access to care across the entire population, to compare alternative strategies for workforce deployment, and I might add for site of care, alternative choices for where particular services are delivered. So that's improving health systems. Communication and dissemination research is about how do we get the evidence out, How do we disseminate it? What works, particularly taking into account variation in population language literacy? And how do we understand and enhance shared decision-making once the evidence is available? So that's the third. And the fourth is addressing disparities. This has a lot to do with the fact that we do understand that efforts from pharmacotherapies to public health interventions don't work the same for everyone. If we're not careful, our interventions can actually exacerbate disparities. So we're very interested in studies that address eliminating disparities. They might actually study an entire population and aim to eliminate the disparity, or they may study just the population that's experiencing the disparity and show that they can improve outcomes in that group. And the fifth of these priorities is, we call it the infrastructure priority. It's about improving the methods for doing patient-centered outcomes research, or CER, the analytic methods. You know that we have a methodology committee which spends its time identifying gaps in the methodologic portfolio and then working to fill those gaps. But also, very important, and probably where more of the resources will go, is building a data infrastructure for conducting this kind of research. And I'll say a bit more about that in the end. But just to point out that particularly these three priorities seem to me to just really resonate with a public health community. And so I think that there's a lot here for us to talk about. Again, comparative framework, but how one improves delivery at a system level, be that a health department, be that a state. Another thing that was said this afternoon at that same session that Lisa Simpson chaired was an urging of the audience in this room to really think about the natural experiments that are going on. Natural experiments are always going on, and with data they can be studied, and certainly it's never more true than now and in the next several years. PCORI is on record as saying we're very interested in studying natural experiences, experiments, policy interventions, different, and again in a comparative framework. So 2 states, 2 counties, 2 health departments choose alternative ways to approach a particular challenge. We'd like to know which one works better. We'd love it if it was 20 departments, 10 of them did it one way and 10 of them did it the other. So just an example of a study that we funded just in December, a very nice study. This is in Seattle, where a clinic community liaison is working with patients to strengthen the connection between clinic care. Basically, I believe in this setting, it's being delivered through patient-centered medical homes and the services in the community. So engaging patients actually in designing this community clinic liaison role to be used by primary care teams. And again, this is evaluated in a comparative fashion. It followed up on an extremely promising pilot intervention. And the reviewers felt that it was both very patient-centered and also very focused on a real-world practical question. This is another nice study. This is a study where working with a group of FQHCs, these investigators from UCLA, looked at, and working with patients from these community health centers and clinicians from these same centers, they looked at enabling services, that is non-clinical services that help patients, particularly vulnerable patients, low-income patients, take advantage of healthcare and achieve better outcomes. So 2 nice studies that I think really do kind of land right at that interface of clinical care and public health. Just briefly about how we see ourselves funding research. There are 2 pathways and we will continue to pursue both of these pathways. The first looks more like NIH conducts research, in that it's an invitation to investigators to partner with stakeholders and respond to very broad announcements. Some of you may have seen these announcements. They've been up since last May. You can respond every 4 months. And here we simply ask you to bring your patient and stakeholder partners with you to the application, and in the application to tell us why this is important, why it's likely to change practice, and how you're going to do engagement throughout the project, as well as the study design, the methods, and the usual components of an application. I've told you about the peer review, the study sections and their composition. They review on the standard criteria that you get reviewed on at NIH, but they also add in, is this patient truly patient-centered? Have they engaged patients and stakeholders appropriately? And is it likely to change practice? So it takes twice as long to review the grants, study section members tell us, and the scores are a little higher in general, we see. But the patients, stakeholders, and researchers who come to the study sections claim that they really enjoy working with each other on these topics. So that's process number one, the investigator-initiated path. Process number two, which is taking off a little bit slower because it's more complicated to get into place, begins by PCORI talking with stakeholders and generating questions in that fashion, just in conversations or in by looking at for example, the results of systematic reviews or the results of guideline development efforts. Through a variety of ways, generating questions, prioritizing those questions, and writing funding announcements on the highest priority questions. So this is more of a top-down, but at the top, along with PCORI, are our patients and stakeholders. Again, we invite researchers to partner with patients and stakeholders and send us their proposals. The rest of it looks the same. We review it with the type of peer review panel I mentioned. So that's the second pathway, and we've identified our first targeted announcements. You can expect a number to follow in short order, but the first 5 are treatment options faced by women, particularly women who still would like to be able to conceive and bear a child, treatment options for uterine fibroids. The second is the safety and benefits of treatment options for severe asthma in African American and Latino patients, where prevalence is higher and mortality is higher. And there's some evidence that certain treatments, that there's real treatment heterogeneity to the extent that treatments that work in one group can be harmful in another. Fall prevention in the elderly is the third targeted topic. Back pain is the fourth, and prevention and management of obesity in clinical settings is the fifth. Again, there is a nice instance where, with respect to obesity, one could easily conceive of a study where you would say, does it really make sense to address this in primary care, or is there a role for a public health or a community-based approach? This is just the advisory panels that I mentioned. We begin with generating the topics. We work with ARC to prepare topic briefs. The advisory panels, which are now convened, which are now composed and will meet next weekend for the first time, get together to prioritize topics, and the prioritized list goes to our Board of Governors, and they make the final decisions on what will be turned into funding announcements. Okay. I want to say just a bit about treatment heterogeneity, because I think really this is novel. I think this is difficult to do. It has not been done much in clinical research over the years. If you look at clinical trials, they typically have been powered to detect just a difference. They've been, the mantra is clinical trials are costly. We do them just large enough to detect the difference we want to find. That leaves you unable to really look at whether the treatment works the same for everybody. You don't need to do this in a clinical trial setting. Observational data may be very good for this at times, and you don't need to confine this to clinical questions. Public health questions may be just as good. This comes from the legislation. They told us in the legislation that the study should be designed to account for the potential for differences in the effectiveness of healthcare treatments, services, and items as used with various subpopulations, et cetera, right on down to genetic and molecular subtypes. So probably the force that was most influential in getting this little piece into the Affordable Care Act was the pharmaceutical industry, where there was concern that we would do simple comparative effectiveness studies, find out that we couldn't see any differences on average, and policymakers would say, therefore, we'll cover the cheaper drug and leave this new drug completely off the table. Pharma offered that sometimes drugs may work better for a subgroup, and you should be looking for that. There is self-interest in that, but there's also some wisdom, and I think really looking backward at clinical trials, pooling clinical trials and looking for this, and building this into design of future studies makes a lot of sense, and we actually ask applicants to address this question in their applications. One size clearly does not fit all. Just some examples. In breast cancer, we know about Herceptin, trastuzumab. You do the gene expression test on the breast cancer tissue. If the gene expression is positive, you know that trastuzumab works, and if it's not, you know that it won't. In atrial fibrillation, you can, if you're going to use warfarin, you can do a genetic test to determine whether this person will metabolize the warfarin rapidly or slowly, and therefore this, at least in theory, can guide you to the optimal initial dose, and people can get anticoagulated and prevent stroke more quickly and more safely. In depression, it is known, it has been demonstrated that being married and having good social support, as well as having less severe depression, is associated with more effective antidepressant therapy. In intensive care unit admissions, prediction scores can show that more aggressive care will benefit people with a certain level of risk, but if the risk is beyond a certain level, aggressive care is much less likely to be of benefit. And lastly, the example of, which is more like a public health example, of large population with type 2 diabetes. You're considering an e-health or now an m-health education effort, and the marker here would be literacy and numeracy, and the chances are, there is a chance at least, that patients of low literacy and low numeracy will not benefit from this, and your nice intervention will have a heterogeneous effect and may even exacerbate disparities, improving outcomes for patients who are literate and not for those who have lower literacy. So just examples across the spectrum of the kinds of questions we could ask where it makes sense to look at population subgroups and ask whether your treatment really needs to be tailored more extensively to work in all subgroups. I was really pleased to find that this notion of one size does not fit all has already, by the Joint Commission, been applied to eliminating disparities and serving diverse populations. Just finally then, a word about a national infrastructure for patient-centered outcomes research. We convened a conference. It was really our first large workshop in Palo Alto in July of last year. And we really went into it thinking that we wanted to invite all the folks from big integrated systems who had their electronic data lined up and they were building research networks and figure out what the next steps were there to get to the point where we could rapidly and efficiently do major comparative effectiveness studies, including clinical trials. And it came down that, you know, it's still very difficult to recruit patients in these settings. In fact, we don't ever even, these networks would, I'm paraphrasing or putting words in their mouths, but we don't talk to patients by and large. You know, we're about the data. And by the way, the systems are not very interested in us doing clinical trials either. We also at this meeting, though, had a number of online patient communities represented. And these were organizations where patients had gotten together on their own because they were highly motivated to participate in research. So we came out of it thinking about, rather than one type of network, two types: clinical data research networks and patient-powered research networks. And we're pretty convinced that there's much to be learned from each type, and that ultimately they need to come together so that the patients in the covered databases are themselves motivated, activated, participating in the governance of the infrastructure, making decisions about what studies will and won't be done, and then, when appropriate, participating in a particular study. So we're very excited by this. You can, let's see, let me just go on to this and then I'll say that last, you can. So at the meeting, we pointed out that these would be the desirable characteristics of a system, and I think it's useful to think how public health data plays a role in these kinds of systems. So first of all, the ideal data, the structure, infrastructure, needs to cover large populations, because much of this research really, you know, if you're going to study a particular disease, many of them are not that common. You need a large population to generate the patient population for a study. It must be diverse. It must be defined so you really know who's in and who's out, not only on day one, but throughout the follow-up. It needs to be able to capture complete data over time. If this is an outcome study, you don't want to miss half the outcomes, and you certainly don't want to miss half the outcomes in one group but not the other. So it's got to convince you on day one that you really are capturing complete experience of people over time. It has to have a capacity for collecting patient-reported outcomes. It has to have active patient and clinician engagement in governance and use. And I notice I add there clinicians. Clinicians are a key part. They play a role in generating the data, and so they, along with patients, really need to be involved in the governance and use of this infrastructure. It has to be efficient in terms of costs. Many previous efforts have foundered on the extraordinary high costs of doing this, and I think in part that's because they've been treated more as research projects and not as projects that interest the systems or the patients or the clinicians that are generating the data. So our view of an ideal system is one that has strong links to patients, strong links to the clinicians, and strong links to the health systems that are generating the data, for the support that that brings, for the sustainability that that may bring, and so that the findings, when the findings are generated, so that they can be disseminated. And lastly, I've already said this, but they've got to be capable of randomization. Systems really need to come to grips with the fact that some of the crucial questions they need the answers to are still today and forever going to need randomization. It might be cluster randomization. Sometimes and increasingly, I think we'll be able to use cluster randomization, but it's got to be randomized. So that's our view of the ideal data structure. You can probably find something somewhere tonight. I know that it has gone out. If you're on our mailing list, I know that announcement of a press conference 2 weeks from today, the 23rd, we will announce a rather large funding initiative that takes the first step towards building on what's gone before, building on what the FDA and the NIH and AHRQ have already invested in this area, but attempts to push it in this more patient-centric, more practical, more based in the real world, useful to the system direction. And just the final slide here, I just thought about, from the perspective of public health systems researchers and systems practitioners who have access to data, how could public health data play a role if most of the data we're talking about is data based on clinical experience? Where does public health data come in? Well, multiple ideas occurred. The first is that oftentimes public health data may provide contextual data. So we're studying something and we're studying it across a geographic area or a socioeconomic area. Contextual data, even at an aggregate level, may be very useful for looking for that treatment heterogeneity that I mentioned, or for otherwise for adjusting for differences that patients experience depending on where they live or their socioeconomic status. So contextual level that I believe is probably, and particularly at an aggregate level, fairly widely available, is one type of data that would be useful in and integrated in a research network. By the way, I would say, we envision these networks as usually being partnerships between two or more entities. Few entities have comprehensive longitudinal data. Few integrated delivery systems, like where I used to work at Kaiser Permanente, arguably did, but not many. And arguably, you don't want an infrastructure built solely of Kaiser Permanente data. You want to see, you really want to see how things work in the rest of the world as well. This kind of data could certainly provide surveillance information that is a tip-off for the need for comparative studies. So surveillance data is a crucial part of an infrastructure. Sometimes certain public health data may actually be able to provide the outcomes for a CER study. And most obvious to me is that they may well provide the best outcomes when we're aware, quantitative and qualitative, when we're aware of natural experiments. For example, two ACOs plan to tackle something completely differently. and public health data may well be the best kind of data to monitor whether outcomes differ at the baseline and whether they change over time. Health insurance exchanges is another. So I hope I've thrown a few ideas on the table, and I'll look forward to your questions about comparative clinical effectiveness research, PCORI style. And just say in closing, please think about joining us if you haven't already by visiting our website. You can go there and submit questions. You can go there and make comments. You can go there and sign up to be a reviewer. For goodness sakes, we love reviewers, and really I think reviewers do have a good time. We've been convinced that we may have to increase the stipend because it is hard work, but people go exhausted but saying they had a good time. And also just keep an eye out for funding opportunities because they will be coming rather rapidly over these next 6 months. So thanks for your patience, and I will be really happy to take questions.